potentially what's happening is that people who are thought to have interstitial cystitis, actually what they've got is probably a chronic infection with persisting symptoms. But, the minute you start talking about giving a woman with a UTI a course of over a week or two, and people are starting to think, oh my God, what are you doing? Why are you doing this? And as if somehow that same antibiotic used for essentially the same bacteria, because guess what causes prostatitis is E. coli predominantly. Same antibiotic, same bacteria used on a male condition, we're all right to give it for several weeks, no problem. And particularly if you're beginning to, you're starting to get some level of bacterial persistence, then giving a short course doesn't make any sense. In fact, in the laboratory, the way you induce resistance in bacteria is by giving repeated small sublethal doses to a bacteria. And I think that's one of the messages that we're trying to get across to people, is that do trust patients because they are actually quite reliable in this condition.
Hi, Mr. Ased Ali. Thank you so much for coming on.
Hi, pleasure.
So you're obviously a consultant urologist, and what interested me was that you've got a PhD in immunology and recurrent UTIs, which I think is a super important topic. So starting off with that, what is a recurrent UTI?
Yeah, so that's interesting in itself. Originally, there wasn't an agreed definition of this. But I think over the last few years, on the back of a few trials, this has become better recognized. A recurrent UTI, most people would now define it as either 2 UTIs in 6 months or 3 UTIs in a year, and that's increasingly becoming the accepted definition. But that's by no means always been the case as a definition. If you look back historically at papers, they won't necessarily do that. But in more recent years, that's what we're saying. I think one needs to, though, make a distinction of that. Then that's recurrent UTI. And when we say recurrent UTI, what we mean is you get a UTI, it gets treated, or, on its own, it gets better, and then you're okay for a while. And then another one comes. So there's like a gap between those two. That's different to what is called persistent UTI or chronic UTI or embedded UTI. And these are sort of different terms, but these are sort of the symptoms where, in a way, the symptoms never completely go away. So you get a UTI, maybe it gets a bit better, but the symptoms sort of hang around, and then maybe it flares up again, or maybe it just never. You've just continuously got a low level of symptoms going through that don't really respond to it. So there is another entity. Now, again, those two often get sort of talked about interchangeably. When people say recurrent UTI, but people and often patients, when you talk to them, they'll say, well, it never really went away. It's always been there, and often that still gets labelled as recurrent UTI. But I think that's actually probably something slightly different. It's probably something like chronic UTI or persistent UTI. Now, bacterially, we do recognise the difference. That recurrent is you've got a discrete bacteria, and then maybe the same one, and it comes back again, and that's a recurrence. And then persistence is that the bacteria just persists there. But definitely, I think medically, people are quite happy to use the term recurrent UTI. But actually, when you talk to patients, there's definitely a group of patients who don't get that kind of strictly a recurrent pattern. It's more like a recurrent flare-up, but the thing never completely settles. And that's and I think there's a feeling that maybe it's a slightly different entity, as it were.
Yeah, I mean, one thing as a GP, one of the biggest things is urine problems, right? And I often see that the people that have got recurrent UTIs now, to me, is quite clear. But is it in the clinical workforce? How good do you think the education is there for doctors about treating recurrent UTIs? Because the guidelines are a bit shoddy, right? In my opinion, in treating.
Yeah, I mean, in fairness, I think NICE has been trying to work on this, and things have definitely improved. But I think there's almost like a clash here, isn't there? On the one hand, we've got legitimate concerns regarding antibiotic prescribing. I mean, let's be honest, there is a big problem with increasing antimicrobial resistance, and there's an issue about antibiotic stewardship. And I think particularly in primary care where you are, it's a big deal, isn't it? It's something that, is monitored for really good reasons. You've got that on one side. And then on the other side, you've got this recurring infection, which for a lot of people, the only thing that really seems to help to any great degree seems to be antibiotics. And so but, especially in primary care, it's a massive dilemma about, okay, this person's got an infection, I need to treat it with antibiotics, but, how many times again, before you know, you look at someone's patient's record and they've had, like, I don't know, 20 courses of antibiotics in the last couple of years or something, something along those lines. And that then starts ringing alarm bells. And so I think that's part of the problem, is that this conflict between what we need to do from an antibiotic stewardship point of view versus we've got patients here that have got this problem. They've got recurring symptoms, the recurring infections, and how you deal with that. So I think that's part of it. And then, yes, our knowledge in this area has been changing, has been growing. What we thought was the causes, maybe clearly it's not as clear cut anymore. There's been newer science coming through. And so all of that, when you put all of that together, it does create a complicated situation.
I think we'll talk more about the treatment in a bit later on, because I want to go specifically into you mentioned about persistent symptoms and embedded UTIs. And there's still kind of a lot of, especially amongst doctors, in the last few months, I'm beginning to realise a lot of kind of contention about embedded UTI actually being a condition. So,
absolutely.
Yeah. So, what's the difference between a UTI and a chronic UTI? How does one get a chronic UTI? And what is an embedded UTI?
Yeah, well, no, again, great question. And unfortunately, the answer is not straightforward. And the reason for that is that this entity, and that's why I was using a number of different terms, because a number of different terms are used: chronic UTI, embedded UTI, persistent UTI, biofilm UTI, lots of terms. It hasn't been clearly defined. So in the way that I said recurrent UTI, we've got this definition, that's largely nowadays accepted. Even that, we didn't have it until maybe a few years back. Chronic UTI, persistent UTI, or embedded UTI, as a clinical entity, hasn't been clearly defined. However, if you speak to both clinicians in primary care and urologists, urogynecologists, general physicians, anybody who's involved in managing this, and certainly patients, they will recognize this entity that I was sort of describing before, where you get these symptoms that never seem to quite go away. It might be that it flares and reduces and flares and reduces, or it might be that it just stays at a consistent sort of medium level, or even worse still, at a very high level. But the thing that's in common is that it just doesn't seem to quite go away in the way that we normally think of a urinary tract infection as a discrete event. You treat it and the symptoms subside. It might take a little while for the symptoms to subside. It could be a couple of weeks, might even be, if it's a really bad UTI, it might even be a month or so. But generally, the symptoms go away and the person gets back on with normal activities. With what we see as chronic UTI is this sort of persistence of a symptom. That's one element of it. There's a second element of it that's recognized as well. And that is that often they've got the symptoms, but when you look at the urine and when you do a urine culture, often nothing comes up. The urine comes out. They have a urine sample, and then you're left with this clinical conundrum where you've got somebody, to all intent purposes, it walks like a dog, barks like a dog, looks like a UTI. They've got the symptoms, and they may even have some level of response to antibiotics. It helps, when it's flaring up, it helps reduce those symptoms. But when you do a urine culture, it just comes back as nothing, either no growth or mixed growth or something along those lines. Certainly not. You won't get the sort of usual 10⁵ coloniform units that you normally look for in a urine culture by the classical CAS criterion. And so that creates this other dilemma that, is this a UTI or is this not? Is this something else? And then sometimes people then start to get diagnosed with another entity, which is something called interstitial cystitis. And interstitial cystitis is meant to be a diagnosis of exclusion, whereby you exclude everything else, and then if you've still got these sort of symptoms, then people think that it's due to this interstitial cystitis. And so essentially, it's a form of cystitis that has an inflammatory reaction but doesn't involve bacteria. And people begin to think of that. But here's the problem. That's the sort of kind of thinking that has led to that sort of diagnosing interstitial cystitis. And almost certainly there probably is an entity that is like that, where you've got inflammation, you haven't got bacteria. But what we now know from more, from more recent science is that when you get certain types of chronic infection, the bacteria actually get into the wall of the bladder. They're actually inside the cells. And they've done that. They originally did this in animal models. They did it in mice. And then they've shown the same thing in humans. And you can model, and you can actually, you can use fluorescent bacteria that tagged and even see them inside inside. Yes. So we now know this as this is something that happens. But here's the thing: once they're in the bladder wall, you can't detect them. Where do you look for bacteria? You look for it in the urine.
Yeah.
But if they're inside the wall of the bladder, they're essentially hidden to your urine culture. And so that in itself then starts. So almost a part of that condition is that it becomes difficult to detect. There are other factors that probably throw in as well. That generally, if you've got a urinary tract infection, you tend to drink a lot more, and that may be diluting out whatever bacteria is in the urine is probably being diluted out, and there are probably other factors that confound this. But this is a big thing. This idea that you've got these what you call intracellular bacterial colonies, IBCs. We've now known about this for about 20 years now, since the original animal work and stuff was done. But that changes the way we look at this. Normally we taught is, someone's got cystitis, has symptoms, get a urine culture, shows bacteria. Hopefully in that bacteria also you get some sensitivity on antibiotics and you treat it with antibiotics. Here you've got bacteria, but they're hidden. They're actually within the bladder itself. And that mechanism of insertion of bacteria, that is part of its evasion mechanism. It's trying to evade detection both by the immune system. It's how it persists. And as those shells then get shed from the lining of the bladder, they then back into the urine. This is part of why you get this sort of up and down sort of flaring of symptoms. But it creates, from a diagnostic point of view, it creates a problem. But in answer to your original question, which was in relation to chronic UTI, how do we think about it? I think these are some of the features that we know are part of it. This idea that the symptoms don't seem to completely go away, often difficult to detect. And then a third one might be that is, the way it responds to antibiotics. Often they require, either sometimes you see more limited response, or it requires much longer course of antibiotics to get that response. And one of the theories for that is that it takes time. The antibiotics have to be then, as those bacteria in the cells that they're embedded, as those come to the surface, you begin to. That's when the antibiotics can get it. Because while they're inside the cell, the antibiotics can't get at them.
Sorry to cut you off there, because it's quite an interesting point where, cause I think it's quite important for people to understand is that obviously with the symptoms of urine infection, the bacteria generally tends to be in the urine itself. But what happens, we now know, is that the bacteria embed into the wall of the bladder. And whilst that's happening, that the patient can be potentially symptom-free or very low-level symptoms. Is that correct? And then obviously the bladder lining has to shed as part of, everyone's bladder lining sheds. And the bacteria fall off the bladder lining into the urine. And that gives you the symptoms. But of course, the rest of the time where it's embedded, that can go missed, right?
Exactly. And when you think about it from the bacteria's point of view, it's a pretty clever way of hiding yourself and coming out. And you're essentially, you've almost like hijacked the body's own defenses. So one of the defense mechanisms that the body uses is to shed the cells. That's why when you've got a urinary tract infection, what happens to the urine? It becomes cloudy. And it's not just cloudy because there's bacteria in there. It's cloudy because your own cells are being shed. And that's the way your body's trying to get rid of those bacteria. But what it's doing is that while it's embedded, it's almost like it's hidden. It's hidden to our diagnostic cells. It's hidden to a certain degree to our immune system as well. And then as it comes out, then you start to get the flare up, and then your body starts attacking. And this cycle can persist. One way that is hypothesized to break that cycle, and we do see that, is that if you've got a longer course of antibiotics that seems to stays there, then as those bacteria, as they come out, they get then dealt with, and eventually you get to a point where you've got new lining of bladder that has come up that hasn't got any bacteria within it. This is very different to classically the way we've thought of urinary tract infection, where basically the infection is an ascending infection. It's coming from sort of tissue, essentially coming from bowel, basically. And the bacteria migrating up the tissues near the genital So and maybe it colonizes the area around the vagina in women, or around the perineum in men, and then it migrates up the urethra, the water pipe, and up into the bladder. And that's probably how most UTIs do start. But this is like almost like an adjunct that once it's in, it then finds a way to to get into the cells and hide within there. And the other interesting part of this hypothesis is that there is also a theory that this is somewhat driven by antibiotics. And that if you give somebody a short course of antibiotics, what it tends to do is it pushes the bacteria to try and want to do that, because that's how they're going to escape. And so, and the reason this is all a theory. This is not, we don't know for 100% for sure. But the reason is that reports of chronic UTI and this sort of persistent type symptoms do not, and recurring UTIs don't seem to exist in the pre-antibiotic era. And so there is this theory that maybe antibiotics are actually pushing. It could just be that, okay, maybe people had this and they just didn't present to people. They just put up because they didn't know, how it's going to get treated or whatever. But there are reports of, UTI and cystitis, etc., going back, centuries. It's not like a new problem. But this sort of repetitive, either recurring or persisting symptom, seems to be there. And we're now even seeing statistics to showing the number of the number of admissions for UTI continuing to go up. NHS Digital shows that. Plus, we're seeing this other entity that I mentioned earlier called interstitial cystitis, which is meant to be an abacterial UTI, also going up in terms of the number of things we're seeing. Which again, sort of fits with this idea that, hang on, there's more people getting these symptoms. And what's happening is that people who are thought to have interstitial cystitis, actually, what they've got is probably a chronic infection with persisting symptoms, and the bacteria just in, and they've been called interstitial cystitis because no one could pick up the bacteria in the urine. But actually, the bacteria in there, we just don't have the appropriate test. If you could test the tissue in their bladder, probably you would be able to find it. But that's more of a kind of a scientific sort of research type test at the moment. It's not something that you can do on a diagnostic way within clinical care.
That's interesting. I think that goes quite nicely on to diagnostics. And I think in particular, what we can start with is kind of why is the current, the NHS way of testing and the CAS criteria kind of really outdated, and why it doesn't catch these?
That's good. That's a great question as well. So, I mean, I think there are a number of problems. So CAS criterion, I think the original paper was published in the late 1950s, and it was actually it was published on a group of women during pregnancy with with what we call ascending infections or kidney type infections. A very different kind of population to the sort of standard simple UTIs and then recurring or chronic UTIs that we see today. So right from the outset, it was like a slightly select group. And basically, they set this threshold that, above this certain amount, it seemed like somebody was more reliably to have a UTI, and below that was not the case. As far back as the 1980s, there's a paper being published by a prominent clinician called Stam, showing that, hey, this doesn't right. This is this 10 to the 5 is too high. You miss a whole bunch of people who've got an infection, and he was proposing even then, look, we need to lower this.
So what you say, the current criteria is still based on the CAS criteria that was done on pregnant women in the 1950s who've got pilot.
Yes, correct.
So that threshold is obviously going to be, way too high.
What's the relevance? And there's a number of us. So even at the time, it was kind of slang, but okay, that's what they did, and you've got to start somewhere. And this is not a criticism of what CAS did at the time. At the time, it was, it was a good place to start. But, it's been a long time since then. We're in 2025 now. We're still using something from the late 1950s. So the first problem is that even the population defined on was probably not appropriate for most things. Secondly, the threshold is very high. It tends to miss a lot. And then I think we come to the next point of view, is that even within, we're still talking about a very traditional type of culture, of way of detecting bacteria, which is by culture, where you grow stuff out. There's very little now that we detect microbiological where we do that. Urine is one of the few things. I mean, we're all now familiar. Everybody is familiar now with what we call PCR, polymerase chain reaction type things. We all used them. We're all doing them when we were swabbing ourselves during the COVID period. So that has become one of the mainstays now, detecting other forms of microbe, whether it's viral or bacterial. And there are also more enhanced ways of culturing as well. If you are going to grow the bacteria out, because there are advantages to growing bacteria out, because then it's easier to test for antibiotic sensitivity and things like that. But again, the way this is done is on a very basic way. You can plate it out on an agar plate. But even that, they tend not to do generally because of the sheer volume of analyses that need to be carried out. They used to get put through these high flow machines, which all they do is they initially detect the number. And if it doesn't hit that threshold, then that's it. It never even gets grown out.
So if it doesn't hit the 10 to the 5, it doesn't even, they don't even take it for culture.
No,
it's like, and
so you don't get to the point of even growing it out. And then even if you do grow it out, you actually grow it out on one particular medium and try and see what that is. And we now know there've been a number of different publications looking at the problems with this, and where people have grown out the bacteria in urine from using higher volumes of urine and in different types of media, and found much higher levels of bacteria and much more sensitivity. And they estimate, I mean, there was one study on this thing called EQUAC, enhanced quantitative urinary culture, that showed about half of all bacteria are missed in people who have actually definitely got clear UTI type symptoms, and they're still beyond the conventional culture. They're not showing any growth, and yet when they do one of these enhanced cultures, you see that the bacteria are there. And then if you do it by a PCR, which is even more sensitive, that's this molecular technique, the kind of thing that we used a lot during COVID, then you get even higher sensitivity. So it's pretty clear that the conventional urine culture for detecting is pretty inadequate. If it comes back positive, yes, no doubt it can give you some useful information. You've got back, you get a grow, shows you some bacterial sensitivity. Great, you use those antibiotics, and that's kind of the conventional pathway, and it's great when that works.
Yeah, I think. I know this. Maybe we can talk a bit about exactly how they test the urine, because so obviously the patient gives a urine sample, and then they put it through the analyzer, initially find out the number of bugs in there. But then say if it does meet the threshold of 10 to the 5, how do they actually, just so we can compare how the other testing diagnostics are done, but in a traditional culture, what happens next? What do they actually do in the lab?
Yeah, so if they do, if it does reach that threshold, then they will look to plate it out onto an agar plate. Different labs will have slightly different protocols. And when I say 10 to the 5, I don't think it's completely rigid. They're probably a little bit below. They will almost end. But basically that's the thing. And there are some places where they will lower that threshold more, but that's the general threshold that is used. And then they play, and then they'll see what grows, and they'll do sensitivities. They use antibiotic discs to see what is growing. And the other issue is that if it grows more than one bacteria, so conventionally UTI defined as you should have one predominant bacteria. But if it starts growing several bacteria, then again it's regarded as as either contaminated or not indicative of UTI. And again, that approach is not always correct. I'm not saying that don't get me wrong, a monoculture where you've got a clear predominant bacteria, that is definitely a good indicator, and conventionally it is the right way to go. But you can end up with situations where you have got another bacteria, and it's not uncommon to say, for instance, you've got predominant E. coli growth, but you might also see a little bit of Enterococcus, etc. So again, there can be this issue where you don't get a result, but actually there was some growth there. It's just that again, it doesn't meet the relevant criteria.
So what are it sounds like the standard culture is not very good at all, actually. So, and I'm guessing it's done because of a cost saving thing. It's probably the cheapest one, I suspect. But so what going on there? You mentioned sort of the enhanced study, and PCR. But how do they work? And are they the only ones? And
no, I mean, there's a different. I mean, I think there are different. I mean, I think there are two examples. One is still in enhanced quantitative urinary culture, still type of culture. But what they do is they grow, they use a higher volume, grow up for longer, use different mediums. It's not one type they use it, and as a result, they get much better sensitivity. And I would call that as almost like an enhanced, a significantly enhanced version of what is done with more conventional culture. But obviously, it takes longer, more effort, more materials. And then you've got PCR, which is a completely different technique, and that doesn't involve growing the bacteria. Instead, you're looking for the sort of molecular fingerprints of the bacteria, and then you use various techniques to try and quantify that. And then the way you work out what antibiotics you can use is more looking at it almost from what genes they carry. So looking at whether they've got resistance genes to certain things. It's a very, very different kind of way, but it's incredibly sensitive. I think one of the problems with PCR can be it's almost too sensitive. You can pick up so much in there. So you actually do need analytical tools. And these have been developed now that help interpret that for you so that you know that, okay, this is relevant, this is not. Because you won't just pick up bacteria that are causing infection, you will pick up other things as well. But for most things now so for instance, a great example, sexually transmitted infection. Again, that's another genito-urinary infection. Guess what? We never use culture to test those anymore. It'll always be PCR. And as I said, already mentioned, we've all got experience of using PCR during the COVID era. So this is now the standard of care for many other types of infection. But yes, I think you're absolutely right. Urine, the sheer volume of them means that there is a cost associated with that. And for that reason, it's difficult at the moment to switch over to another form of testing. I don't think anybody's necessarily advocating that we wholesale switch to that sort of testing. No, not at all. But I think where there needs to be a recognition is that where you've got patients who have got these sort of chronic symptoms where they're being told that, hey, no, there's nothing in your urine, you haven't got a urine tract. Hang on. No. They haven't got anything in their urine on the conventional culture. But probably if you did use some enhanced techniques, you probably would find something. And maybe it's those people that we should really be willing to focus other types of analyses on so that they get an answer as to why they're getting this. And that can then actually help direct treatment as well. There are even some very simple ways as well within chronic infections. So one under the laboratories in London, they don't even look for the bacteria. They actually just look for white cells, and they look for what they call leukocytes, white cells.
That's called microscopy, right? That's
the microscopy. Now, there are positives and negatives to that approach as well. The big positive is it is quite sensitive. It gives you an idea that there is some inflammatory process going on, and the most likely cause of an inflammatory process is probably an infection. There are other causes, but that's the most likely infection. The downside of that is of course, it doesn't tell you what it is, what bacteria is, and it doesn't tell you what antimicrobial you should use on it. So what antibiotic. But the clinics that use that technique, they have certain protocols for what kind of antibiotics they will use and in what sequence. And so that's that's an approach that has been used effectively in patients who've got this problem.
So with the enhanced, that's done in the broth culture, is that? Because I know a lot of people use the term broth culture.
Yes, that's another type of culture. Yes, it is. I think when we talk about broth culture, that's probably a more nebulous. So enhanced quality urine culture was a specific protocol that was in. But yeah, broth cultures is a broader term that captured it as a number of different types of cultures, but they're all sort of similar, slightly different protocols, but basically looking at using more urine, growing out for longer, and using a number of different types of medium, and essentially massively improving the sensitivity of the test.
Yeah, you're not mistaken. I think the standard ones, the standard cultures are kind of the culture used is kind of very, very kind of likely to grow or sort of biased towards E. coli.
That's correct. And that's another issue. And one of the other questions is that look, I think nobody's going to argue that E. coli is the most common infection that you see in urinary tract infections. There's no question about that. I think that is true. However, you're absolutely right. The current urine cultures, the standard urine culture, does have a natural tendency. It's more favourable growing E. coli as well. So particularly in patients who maybe have got another bacteria that's growing or the causative problem, you may be again more likely to miss it. So it's another factor that means that the bacteria that patients have may get missed. So again, great example, something like Enterococcus. You might have Enterococcus infection, and it just might not be picked up on a conventional culture.
I think I'm forgetting just a patient having symptoms of a UTI is very sensitive in himself, right? So say someone's got stinging, burning, might have a bit of a pain. That it's something like 80% accurate, right? How you've done it away. So just having the symptoms is.
I agree, and I think that's And I think that's one of the messages that we're trying to get across to people, is that do trust patients because they are actually quite reliable in this condition. I'm not saying, nobody's trying to say everything's 100% reliable. Nothing is, but they're actually pretty reliable. And to slavishly follow this idea that, oh, well, we have to have a positive culture, otherwise it isn't. I mean, that's just, it just doesn't make any sense. And it reminds me, one of my consultant trainers when I was a junior doctor, he once used this phrase that's stayed with me. It wasn't in the context of UTI; it was in a different context, but I think it applies here. Is he says that you say that a three-legged dog is still a dog, but some people insist on finding the fourth leg. And it's like that here, is that you know that this is a UTI. Are you really? Do we have to get that additional bit before we can accept that this person really does have a UTI? Because they've got all the symptoms. Often they will even respond to the antibiotic treatment, and you're seeing this one clearly a UTI. But to call it not a UTI just because you haven't managed to get that positive culture, it doesn't make any sense.
Yeah, so essentially, I mean, just a quick overview. They're saying someone's got UTI symptoms, the culture's negative, but is ongoing. It should technically be treated as a UTI, and then they can do further testing, like the broth culture or the microscopy, to kind of figure out if it is that. But why do the nice guidelines still say 3 days of antibiotics? And everyone still gets 3 days. Say they come in, and there's lots of problems with that, right?
Yeah, and I think this is a tricky one, because it goes back to the original thing that talking about, and that is you have got this conflict between antibiotic stewardship on the one side and patients who have got some form of a chronic, persistent, recurrent GI. We know that a large portion of patients with a simple UTI, if they are given a 3-day course of antibiotics, that often will just get on top of their symptoms, and that's the end of it, and that's fine. And that's fine. And that evidence has existed for a long time. In fact, I remember the first papers of this coming out when I was back in medical school. So it was like at the beginning of I think it was around 2000 or something, when some of these things were coming through, and people were beginning to then switch over from sort of what used to be standard, which is more like a 7-day or a 5-day type course, moving to this sort of 3-day thing. And there was evidence for that. And I don't think anyone's disputing that for a large portion of it that's way. I think the problem occurs is, number one, there is clearly a group of patients for whom that doesn't work, and leads down this pathway. That's the first issue. The second issue is, once you've got someone who is into that recurring symptom type situation, they are not suitable for that. This sort of 3-day antibiotic that is really meant for what is called, it's, I wouldn't call it necessarily the best term in the world, but simple UTI. It's a straightforward UTI. Got it. They get 3-day antibiotics in. But as soon as you're having recurring episodes, whether that's, discrete recurring episodes or recurring, or it's some sort of persistence with recurring flare-ups, you're not in that category anymore. And to be giving that sort of person a 3-day thing, that doesn't make sense. And particularly if you're beginning to, you're starting to think there's some level of bacterial persistence, then giving a short course doesn't make any sense. In fact, in the laboratory, the way you induce resistance in bacteria is by giving repeated small sublethal doses to a bacteria. And Fleming, who obviously discovered the first antibiotic, penicillin, he himself actually famously said that the thing that he feared most was people being given a sub-therapeutic dose, enough that it would have some effect, but it didn't kill off the whole bacteria, and then what would remain would then be resistant and would be able.
That's so interesting, because essentially it's like the textbook way of creating resistance. You're giving someone enough antibiotics to treat their symptoms at that moment, but not getting the infection completely. They'll come back.
Exactly.
Often get a different antibiotic, and this leads to a massive problem, which is antibiotic resistance. Right? I mean, that's a huge problem right now. I mean, even I've seen in the last couple of years, when someone has got a bug in their urine, it comes back, and a lot of the antibiotics that used to work are now just resistant, and it's unlike.
And I think this is something that really does need more more work and more guys to work out what is going. Why are we getting this? And I think of course we all want to reduce the use of antibiotics, and antibiotic stewardship I think is absolutely essential. But exactly, it's a point. If inadvertently by going for lower but by using lower amounts, we're actually, I just say, where we're just giving more in totality because you're giving it repeatedly. That's not what we're trying to achieve. It's better to give somebody a longer course and then that's it. It's done. And we've beaten the infection, than be giving repeated short courses. So I think this is something that definitely requires further investigation. And I know, one of the hypotheses that professor of clinical medicine in UCL, who passed away, a chap called James Malone Lee, he actually presented some graphs which he had from NHS Digital, which showed that the increase in, things like interstitial cystitis and recurring UTIs and so on. And one of the things that I remember he hypothesized about was that, is this about, because he said that, this issue about the shorter courses, etc., started, at the turn of the century, around 2000. Has that been part of what has been driving this? Of course, this is just a hypothesis, and it could do it, but it's conceivable that in a way, by reducing this amount, and we're almost driving this problem. And if we could get to a situation where we actually beat the infection properly each time, might have some effect on this.
I mean, what your thought? I mean, I don't want to get into the whole kind of gender argument, but I mean, there's other conditions like like prostatitis, for example, which is essentially an embedded infection, right? And you give him, the man will get 2 weeks as straight out the gate. And then sometimes up
to 6 weeks.
6 weeks, even longer than that.
Very, 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 very common. Yeah.
Yeah, but then when kind of, let's be honest, so most patients with these kind of symptoms or chronic UTIs are female, right? But do you think that's kind of like a historical kind of bias towards...
I've often wondered, I mean, again, it's a great point, and I've often wondered that myself, is that why is it okay to give a 4 to 6 week course of antibiotics, urinary infection antibiotics, the same sort of antibiotics for prostatitis? It's okay to give, often even for epididymolysis, that's testicular infection, we'll often also give longer courses, maybe not quite as long, but certainly But, the minute you start talking about giving a woman with a UTI a course of over a week or two, and people are starting to think, oh my God, what are you doing? Why are you doing this? And as if somehow that same antibiotic used for essentially the same bacteria, because guess what causes prostatitis is E. coli predominantly. Same antibiotic, same bacteria used on a male condition, we're all right to give it for several weeks, no problem. But when we want to do that for what is a condition that, let's be honest, is way more common in women, suddenly everybody's up in arms as, we're doing something wrong. And I've never understood that. That is clearly illogical, because it's literally the same antibiotics, same bacteria, just in a different place, basically. So, I think it's a legitimate question.
Yeah, I think it's probably a bit more slightly controversial, but I think it's just something that's been built up in the tradition of medicine, where a female coming in with recurrent symptoms, whether it's fibromyalgia, whether it's, ME-like symptoms, whether it's, menopause symptoms or UTI symptoms, is being deemed as being, not sort of kind of in your head, mental health, or being anxious.
I agree, and I think there is this whole business about anything that's going on in the female pelvis seems to get, you mentioned some of these other conditions, endometriosis, esophagus, it's all, and you're right, it goes back to this, the historical thing, that the whole term hysterical comes from that. And this is one of my big worries about, interstitial cystitis, is that I certainly it's been my experience that a lot of people who have been labeled as interstitial cystitis actually turn out to have a chronic infection and respond to, appropriate treatment for a chronic infection.
So how should someone get,
there isn't such a thing as interstitial, the clear is, I've also seen that. But I think there's, this idea where we get some people who have been labelled as that just because they've got the symptoms, but nobody's been able to find bacteria in the urine. That's where things get problematic. Whereas when you look inside their bladder, it doesn't show any of the features of interstitial cystitis, yet somehow they've been labelled as that purely because they didn't have a bacterial culture.
So let's just quickly cover that. So how does someone get diagnosed with an actual, I guess the common term is painful bladder syndrome, right? A lot of people know it as that. So how should somebody rightfully be diagnosed with interstitial cystitis?
I think that's a good question. Well, I think the first thing is that is also a condition that we don't understand that well. We don't really understand how that starts off. And there's even a theory, and again, it's just a theory that maybe even chronic infection left long enough can develop into that. So maybe it's a precursor or something like that. But I mean, the sort of features that I would personally look for interstitial cystitis is, cystoscopies. Is firstly, I'd expect to see their bladder is reduced in capacity, so they just can't hold as much. There may be other features that when you fill the bladder up, you'll see a reaction within the bladder. So there's these things called glomerulations and Hanna's ulcers. One of the other interesting features you tend to find with interstitial cystitis, generally what they're trying to do is keep the bladder empty as empty as possible. So when they're peeing, actually they get relief from that. Just keeping that bladder as empty as possible will often give relief. In contrast, what you find with chronic urethritis, actually when they go to pass urine, that's actually often when it's quite uncomfortable, because the act of passing urine, just as it is in any UTI, is uncomfortable. Clinically we call it dysuria, don't we? That discomfort of passing urine. Now, I'm not saying that there isn't an overlap, and you do get patients with interstitial cystitis that have discomfort passing urine, and others with chronic infection that maybe don't. So this isn't by any means clear cut, but I think like I say, a bladder with interstitial cystitis does tend to look a certain way. They often have lost capacity. The period that they've had it for, often there's no response at all to any antibiotic treatment. So there are a number of different things you can look at. But equally, I would emphasize that even interstitial cystitis is not clear cut by any means, which is why I think one should be pretty careful to label someone as that until one really has exhausted all the other possibilities that it could be.
So what?
Make sure
sorry to cut you off again, but I mean, what would you do? Say hypothetically, because this is happening a lot. You're a patient who's maybe been diagnosed with IC, but you've still got but you've not had any of the tests, and you've not had a cystoscopy, you've not had anything really done. But you're having all these ongoing symptoms. What should they do? What did you say?
I think if someone's been diagnosed with interstitial cystitis without ever having seen a urologist or urogynecologist and having had the relevant test, then I think that sort of diagnosis is, of course, it was shaky ground. It's not, in my opinion, it's not a diagnosis that should be made in primary care. It's a diagnosis that could be suspected in primary care, and I think primary care clinicians are really good at picking these sort of things up, but ultimately you need some sort of diagnostic. It's not something you go, I think you've got interstitial cystitis, way. I think it's something that really does, and you should have had a number of different tests performed. As a minimum, I think you need to have had a cystoscopy. Someone needs to have had a look at that bladder and get a bit of an idea of what's looking inside and what the capacity of it is. And because it's so uncomfortable when filling that bladder up, often this has to be done under anesthesia anyway, because of the nature of the condition. But yeah, definitely interstitial cystitis. It's classically been called a diagnosis of exclusion. So you have to go and exclude some stuff. You have to go and do some tests and exclude things. So it is something that I believe should be looked at within a secondary care by either a urologist or a urogynecologist.
I agree. I totally agree with that. It's not something we should be able to diagnose, right? Or you should have any diagnosis done by a GP. But okay, so let's go on to treatments now, because this is there's lots of treatments out there, right? But the mainstay treatment for chronic UTI, is antibiotics, but just a long course, right? And obviously we can't say how long, but say if someone comes to see, someone comes to you, they've had, I don't know, a year's worth of 3-day stuff, antibiotics, they've still got symptoms. What would be the kind of, and they say they've got E. coli on their, I don't know, on their broth culture, say, what would be the mainstay treatment in someone like that?
Yeah, so I think first, one of the first things to try and work out is it kind of a recurring or a persistent UTI? Because there are these, and again, I'm not trying to. I mean, I've given an idea, give me a bit of an indication of what the sort of difference is between the way they, but sometimes it's not entirely obvious. But the way you deal with, I think the way you deal with recurring, genuine recurring UTI, there's a number of different treatments that can be used. So, in postmenopausal women, I think one of the first things to try is things like vaginal estrogen.
Which works great, by the way, doesn't it? I've tried that. It works really well.
Very well. If it's recurring UTI due to a particular trigger, so So those we can find it as a result of, it could be after sexual intercourse. You can have sort of treatment sort of dedicated to that time. So you can have what's called post-coital prophylaxis, where you have to take a single dose of antibiotic around the time that you're likely to be at risk. So there are different variants. Then there are sort of non-antibiotic based treatments. So good example, there's things like methenamine hippurate is something that there was a recently great clinical trial led by my friend and colleague Chris Harding. Showed that that's as good as antibiotic prophylaxis. It wasn't inferior, so I think that's a great system. So, and there are a few other sort of non-antibiotic based treatments that can be used if this is recurring UTI.
So
then ultimately you might look at antibiotic prophylaxis as well. So long-term antibiotic prophylaxis. However, if it's persistent UTI, then the first thing you're trying to do is get rid of the persistence. And if you know that if there's something has grown there, then that's going to be your target. And you want to give an extended course of antibiotics to try and see if that can be shifted, much in the way that you would for any other kind of persistent infection.
I see. And so let's go through some of the non-antibiotics. We mentioned methenamine and topical estrogens, but I was going to some that I've come across. So one of the ones that a lot of people use, which I think is quite a good place to start, is D-mannose.
Yeah.
What are your thoughts on that?
Yeah, I think D-mannose is a great example of a non-antibiotic, and it's certainly been effective. And there's now a number of clinical studies that have shown that. What I love about D-mannose, actually, in particular, is the fact that I think this is one that came from patients, and this was not something that clinicians were sort of necessarily saying, hey, we've got this thing, we'd like to no, because that's where we often think of treatments, don't we? The clinicians come with a treatment that ask them to take it. Patients were using this themselves and were finding good responses to that. And that actually triggered then clinicians to start looking into this. And lo and behold, I think there is definitely a value in using that. I think one of the only annoying things about D-mannose is that because it's come through that route, it's still not a prescription drug. And what that means is people have to buy it as typically buy it as a supplement, from a from pharmacist or a health shop, and actually can be quite expensive. It's certainly more than the cost of an NHS prescription, and so I think that's problematic. And I would really like to see that become available through prescription, so that everyone can have who needs it can have access to it.
And what about everyone's favourite cranberry products?
Yeah, so that's an interesting one. So I think there probably is some benefit there, but maybe not as much as perhaps people have thought. I think where there is most likely to be the benefit is probably on the cranberry tablets, where they've really tried to concentrate the relevant component. I think with cranberry juice, really you have to have a hell of a lot to make it worthwhile. And the danger of that is that you're also consuming quite a lot of sugar, which generally speaking isn't good for anybody. It's certainly not good if you're a diabetic, but even from an infection point of view, having lots of sugar is probably not an ideal situation. But yeah, in terms of in terms of cranberry itself, the agent, there probably is some value, but it probably has to come through a tablet, which again brings us back to the same sort of problem as D-mannose. That is, you're probably going to have to get it as a supplement. Costs of that can vary, and the other problem, which again also applies to D-mannose, is the formulations can vary. Depending on where you get it, with different concentration, how effective is one compared to the other. And that's where I think pharmacological medicine, at least we know what we're getting. We know, they're standardized. This is the dose. This is the amount the person should take. I think this is where we struggle a little bit with the supplements. I still think that they're a value, but I think you need to just recognize that we don't always know what the amount from different places. And I think there is this cost issue. And often you're having to use this for quite extensive periods of time, so that cost can really mount up for patients.
Yeah, that'd be. Patients have asked me. Sometimes they bring things to me, and I'm like, well, yeah, it looks quite okay, but you're never really sure because supplements are not regulated, right? So it'd be quite good if there was a way of there's someone that had like maybe D-mannose and cranberry concentrated in one, and they had on the back dosage with the testing certificate show. That'd be the perfect,
yeah. And who knows? Maybe one of the the generic companies, etc., might pick this up if there's sufficient evidence. But it is difficult because once these things are out there in all these different ways, it's hard to roll it back and create one standardized version that we're all using. So in a way, that genie's out of the bottle there. Yeah, I think this is going to continue to be tricky.
Yeah, I mean, so not antibiotics. We've got cranberry, D-mannose, estrogen, methamphetamine. Another one actually that's becoming quite a lot of curiosity about is vaccines. And I must be honest, I don't know that much about them, but I know I've looked at them quite a lot and I've read a lot about them. But a lot of people are interested in
that's right.
Vaccines for chronic UTI.
So, I mean, vaccines have been around for a while actually. So some of them have been out longer than others, and they've taken different forms. The tablet, a kind of vaginal pessary type agent. But the one in recent times it's become very popular is once put in sublingually. There's a vaccine that's used that, and that's that's a relatively recent thing, and that seems to be genuinely has had really good results with recurrent UTI, and the data that's been presented at a number of conferences. So there's a couple of UK urologists, Yang and Foley, who have really done quite a lot of the work on that, and regularly present the data at the urological conferences. As the data's evolving and getting more. So they did the original study, and then they presented it. Almost every couple of years a further update on where they've got, and definitely the results on that look good. I think particularly that one, it works through a different mechanism of action. They talk about something called mucosal immunity. So instead of like a tablet or an injection or whatever, this is because it's going through the lining of the mouth called the mucosa. It's triggering immunity in a sort of in a different way, and that seems to be particularly effective in enhancing the immunity within the bladder. I think there are some ongoing question marks on this. One of them is that, okay, you take this and clearly it's effective for a period of time, but when do you, like with any vaccine, when do you need another amount? When do you need the next dose? Or is, how long is it going to last? Or is it a year, 2 years? How long? So I think that still is there. Also, like many vaccines, there's a possibility that maybe it works better at the younger end of the age group. Most vaccines do, because if you're relying on anything to do with the immune system, you're generally relying on a response, and we know that from other types of vaccine that certain things can work better within younger populations than older. Again, so there are all of these sort of questions that do need answered. But I think that's a really promising area, and I think again, great non-antibiotic treatment. And I think I intrinsically always like anything that helps your own immune system, because ultimately that's what you want, isn't it? You want something that helps you fight infection better, rather than something you have to keep taking that's doing the job. And in fact, vaginal estrogen probably works in the same way. It enhances your own immune response.
Okay, and who would be the ideal candidate for a vaccine? What kind of patient?
So, I mean that's good. I mean, again, I think the ideal candidate is the most of the data is for women, although there is some data for men as well. And the data to be for what we call true recurrent UTI. Again, it comes back to this issue with when we talk about recurrent and chronic. Chronic UTI is difficult to define anyway, and therefore difficult to do a study to show that. So the best evidence is within proper recurring UTI, where you've got episodic in. Whether it's helpful in chronic UTI or not, again, we don't have huge amounts of evidence. Anecdotally, definitely a number of patients have found benefit. But yeah, it does. I think is something that I guess we'll learn more about over time.
Okay, I mean, I think that covers most of the non-antibiotic stuff. But even the antibiotics, we talked about sort of prophylactic and the extended courses. But another useful thing, I think, is going back to what we said about patient symptoms being very sensitive for a UTI, is self-start antibiotics.
Absolutely.
Because I think it's E. coli doubles, like what is it, like 20 minutes, every 20 minutes is doubling your number.
Yeah.
So I think by the time now, by the time you call up your GP, get an appointment, the 3 days are not going to,
No,
are not going to work. So
exactly. Yeah. So I think self-initiated, and this is all in the, just to be clear, this is in the NICE guidelines, postcoital self-initiated antibiotics. These are all recognized and agreed methods of treating. And yeah, the idea is that if you nip this in the bud at an early stage, you're not going to get, you don't get a chance for the infection to develop. Now, just to be clear, because, earlier in the conversation, we were talking about the fact that, short courses of antibiotics, that's not, maybe there's some issues with that. This is not the same as saying giving a short course. No, this is literally at times 1, maybe 2 doses at the time when someone is just getting the symptoms. It's really early. You're trying to essentially never let the infection even establish itself. Once an infection is established, then you of course need a proper course of antibiotics. So this is prophylaxis. This is not the same as treatment. And prophylaxis we do in a number of other situations as well. Classic example is surgery. At certain time of surgery, we give antibiotic prophylaxis. We give a single shot of antibiotic. And the idea is you give that bit of antibiotic at the time when it's very early, and hopefully you've just got rid of everything before it even has a chance to establish. But really glad you brought up the point about the replication, the duplication time. Because every 20 minutes it doubles, and what that means is that when someone, the time between when someone gets symptoms and then gets to their GP or the healthcare provider and then gets, that can be days. Imagine how much that small bit of infection has grown. So that's why self-initiated antibiotics can be very effective, because it nips things in the bud. The other thing that's really nice about self-initiated antibiotics, I think, is from a patient perspective, it gives you back control. I think there's nothing worse than knowing you've got a certain problem, knowing that this is what I need to get on that problem, but I can't get it till 2 days' time or whatever it is. I think that's really disempowering. And I think, given we know how reliable symptoms can be, I think self-initiated antibiotics is very useful.
Yeah, no, I really like using them, especially in patients who know they're getting utilized, so they might get like a slight rumble in their stomach or a slight stinging, and it's really useful for them, I found. So yeah, another kind of, I guess, is more of your field. Obviously, we've done the non-antibiotic and antibiotic treatment is around sort of bladder therapy directly, where you can get things like gentamicin infusion and things like that. Yeah, so what's your experience with those kind of treatments and how effective are they?
Yeah, so I think gentamicin instillation, so where you create a solution of gentamicin, typically in about 50 mils of saline or water, and then inject it into the bladder. You might use some other things like local anesthesia and things like that to further reduce symptoms. I think that can be very effective. The great thing about gentamicin is it's a great antibiotic against a large number of different UTI-causing bacteria. And plus, you're putting it directly into where the problem is occurring. And we know gentamicin has good penetration within the bladder as well, because of the way that its molecule is and the charge and so on, and has very little in the way of side effects because it's not getting into the rest of your body. So that's all of those side things. It's great, and I think it can be very, it can be very useful. And there is evolving data on that. I know they did a study in Bristol where they got patients to use it, even do it themselves at home. These are patients who had a catheter actually in and so on. But there is definitely one or two other studies, and it's certainly being used increasingly in urologic departments. It is still, if we're honest, pretty awkward, because it's not easy to get things into the bladder. You're going to have to put a catheter in and inject it. It's not easy to prepare because, gentamicin comes, it comes in a vial. It needs to be mixed into, so it doesn't come in a ready-made form to do this yet. And I think thirdly, it must be considered it is an off-label treatment. And what I mean by that is that, that there hasn't, no pharmacological company has gone and done a study on this and, produced doses, etc. Yes, there have been studies done by clinicians to look at this and so on, and it seems to be safe and effective. But you can't open up a vial of gentamicin and find in the instructions, okay, if you want to use it as an installation, this is what you need to do. That doesn't, it's off-label. And one of the reasons it will probably remain off-label, probably for the foreseeable future, if not forever, is that it's a very old drug. So there's no pharmaceutical company whose interest it's going to be to go and say, oh, right, let's go and develop this and do this, because it's an old drug. It doesn't belong to anybody. It's a generic drug. So that's both the good thing because it's very cheap, but the downside is it's hard to make it in, in an ideal world, this would come in some sort of kit where it's all ready and you could just easily inject it, and then maybe even patients could do it themselves. You can definitely see an opportunity there. But the problem is that, like many things in healthcare, there has to be a way for people to make it commercially viable. And I don't think, with a drug that's that old, it's just not possible.
Yeah, I mean, so that's one. And also, I've had some patients report good results with sort of GAG kind of therapy.
Yeah,
kind
so
of where...
GAG replacement therapies. Yeah, so it's a GAG stands for glycosaminoglycans. That's this layer, this kind of this sort of mucus-like layer that's within the bladder that normally exists. And so these agents were originally primarily developed to treat interstitial cystitis, because what we know from interstitial cystitis, going back to what I said before, there are types of which clearly is interstitial cystitis, certain changes. So we know from those people where their bladder's been analysed that there's a deficiency in the GAG layer, this glycosaminoglycans layer. And the idea of these installations is to try and replace some of that. So you put it on and it hopefully adheres to the bladder wall, and it helps replace some of that inner line in coating, as it were. People have tried this out then in urinary tract infection, in recurrent urinary tract infection as well. And within that population, we also know that there is that UTI causes an injury to the bladder and can also affect the glycosaminoglycans layer, the GAG layer. And therefore, using these treatments has shown some level of effectiveness. I mean, my one doubt about this, and I genuinely don't know what the answer is this really just a symptomatic treatment? Is it actually doing anything for the infection itself? So, like with gentamicin, that's an antibiotic. I know that's killing the bacteria, or has the ability to kill the bacteria. With these agents, I think they do have some antimicrobial activity, but is that their primary mechanism of action, or is it just kind of soothing the symptoms? That doesn't mean to say they don't have a value. I mean, if you've got recurrent UTI and all of these symptoms, just even soothing the symptoms has value. But is it? I would like to understand better. How are they working? Are they actually doing anything for the underlying mechanism, or is it just is it almost a form of pain relief or symptomatic relief?
No, that's a really good explanation, actually, because I think it's quite complicated, that one. But one thing that's not as complicated but becoming more popular is kind of, I guess, more sort of left field treatments, like almost like natural flora modulation. So people are asking about probiotics and even sort of fecal transplants.
Yes.
Is that a thing? And is there some?
Yeah, I mean, I think again, this is an evolving area. So there was a time when we used to think that the bladder was basically sterile, as in there were just no bacteria and there were very little bacteria. We now know that that's not true. Actually, there is the bladder itself, although it has very low levels, it does have natural bacteria that are there. And just like you do in so many other parts of the body, those bacteria, we call the microbiome, play a role in maintaining the bladder in a healthy state. And therefore, this is the idea of particular probiotics, is that trying to encourage the good bacteria, and particularly in women, we also know that there are good bacteria within the vagina that can stop bad bacteria taking hold there. So when we were talking earlier about the fact that bacteria ascend, up through the water pipe, and often they can colonize the vagina. So using probiotics can help enhance the flora, the normal natural bacteria that are within the vagina, and help hopefully reduce urinary tract infections, and particularly recurring urinary tract infections. So there has been, there is some suggestion that can be beneficial. Again, I think the evidence is still evolving. People are doing studies. It's not an easy thing to work out, really, because everybody's microbiome is a little bit different. Getting bacteria, I mean, it's not just a case of, you have a tablet and the bacteria magically find their way to the right place. I mean, there's a lot of work to be done on how do you get the bacteria in the right place, get them to survive, because remember, our gut is really good at getting rid of stuff. As soon as anything goes into your tummy, it's full of acid and destroys a whole bunch of stuff. So getting the right bacteria to the right place, is it via, is the best way via tablets? Is it via some kind of agent put in vaginally, like, I don't know, cream or something like that? So there's all sorts of lots of questions about this and how this would work. Obviously, one very direct way of changing the bacteria is, as what you were alluding to before, is fecal transplant. I think this is obviously pretty extreme, But there are situations, and I think I've seen it done it's been done in transplant, where you've got patients who've got transplant. So this is really high stakes here, because if you're getting problems with recurring urinary infection, then you've got a transplanted kidney, it could just ruin that kidney over time. And they've detected those bacteria are actually essentially living within that person's bowel. They're there, and so they've gone and done a fecal transplant, and actually managed to change the situation and reduce the UTIs. So I think this is pretty extreme, at least at the moment. However, from a kind of almost like a proof of principle, i.e., can changing the bacteria have an impact on what's going on? It shows that yes, that is something that could be done. So I think this is definitely a space to watch. I know there's a lot across medicine generally in almost every area. People are looking more and more at the microbiome, this idea of what are the different bacteria that we carry, and what are the benefits and drawbacks. So I think we're going to learn more about that. In the meantime, I think it's not unreasonable to try probiotics in these situations. I know a number of patients have had positive benefits from it.
Any kind of probiotic, I'm guessing, that you can buy in a supplement form.
Yeah, I mean, there are certain manufacturers that are producing specifically for helping with urinary tract infections. So I guess that's a reasonable place to start. In honesty, I personally, I'm not saying it doesn't, but I personally haven't seen any great evidence to say that, okay, this is the one that you should definitely use, and this is the one that I hope that comes through. And I definitely have seen studies where people are showing different positive effects, but there's not like a clear front runner at the moment that I could say that, oh yeah, that's the one.
Okay. Well, look, I think this conversation is covered a lot there. But I think just raising awareness of chronic UTI, not just amongst patients, but also amongst doctors, because I think, which is happening slowly actually, I think it's something that needs to be done. But yeah, I think that was a great overview. I mean, it's the second time I'm speaking to you in detail, and I always learn something new. So thank you. But
thanks very much.
Yeah, I mean, I guess we'll leave it there, because I think we've covered everything. So
that's good.